Hi, my name is Harold Moore, and I am a fourth-year medical student at Weill Cornell Medical College. The presentation discusses the use of the osteoporosis drug abaloparatide in enhancing spinal fusion in a rabbit model. Several recent studies have found that osteoporosis drugs, namely teriparatide with the brand name Forteo, reduce the risk of pseudoarthrosis and enhance the quality of bony fusion on CT scans in patients undergoing spinal fusion. In the present study, we examined the drug abaloparatide, which is a parathyroid hormone-related peptide analog, which was originally approved to treat osteoporosis in 2017. In our study, 27 adult rabbits underwent posterolateral fusion at L5-6 with iliac crest autograft. Starting on post-op day 4, the rabbits received daily subcutaneous injections for a total of 6 weeks, and half of them received abaloparatide and half received a saline injection. The rabbits were sacrificed, the spines were dissected, and the fusion site volume and trabecular microarchitecture were analyzed. For the fusion site analysis, 21 of 24 rabbits completed the study. 45% of spines were successfully fused in the control group, whereas 100% of the spines were successfully fused in the abaloparatide group. Pictured on this slide is an example of a notable difference in the fusion volume mass on 3D micro CT reconstruction, which was our region of interest between the abaloparatide and saline treated groups, and this difference was statistically significant. The effect of trabecular microarchitecture was examined as well. We used also a region of interest analysis encompassing about 3 millimeters this time of the vertebral body. The trabecular bone volume fraction was calculated and was found to be significantly increased in the abaloparatide treated rabbits. Additionally, the mean thickness of the trabeculi was significantly higher in the abaloparatide treated rabbits as well. Ultimately, we found that the postoperative administration of abaloparatide increases the reliability and the quality of posterior lateral fusion using a rabbit model. Thank you.
Good evening. My name is Allison Wintering, and this research focused on the effects of local triamcinolone on bone regeneration in a rodent lumbar spinal fusion model. Intraoperative local steroid administration has been shown to reduce the postoperative complications of dysphagia and soft tissue edema in anterior cervical procedures. However, this practice has not become commonplace due to concerns for potential negative impact on bone growth. Therefore, we assess the potential impact of steroid application on spine fusion in a rat preclinical model, as well as on the osteogenic differentiation of human mesenchymal stem cells in 3D cultures. 45 female Sprague Dawley rats underwent bilateral L4-L5 PLF with ACS preloaded with low-dose rhBMP2 with 0.5 micrograms per implant. This level was chosen to avoid saturating the fusion response. Rats received either vehicle control, low-dose, or high-dose triamcinolone delivered locally. The low dose was the weight equivalent to that used clinically, and the high dose was 5-fold greater. Quantitative outcome measures included fusion scoring and micro-CT-based bone volume quantification. Human MSCs were grown in 3D cultures on BMP2 containing ACS with comparable doses of triamcinolone to those used in the preclinical study. Pro-osteogenic gene expression, ALP activity, and mineralization were comparable among the treatment groups. At 8 weeks postoperative, harvested spines underwent blinded manual palpation to obtain a fusion score where 0 was no fusion, 1 indicated unilateral bridging, and 2 is bilateral bridging bone. A score of 1 or greater indicated successful fusion. There were no significant differences in either mean fusion score or fusion rates. Similarly, micro-CT showed no differences in new bone volume among treatment groups. In 3D culture studies, there were no inhibitory effects of triamcinolone on pro-osteogenic gene expression, with the exception of OCN, which was slightly lower in the triamcinolone-treated cells. In this preclinical model, local delivery of triamcinolone did not inhibit bone formation or spine fusion. It also did not impair the osteogenic differentiation capacity of human MSCs, suggesting that the benefits of local steroid application may outweigh the theoretical risk of pseudoarthrosis. Further studies should evaluate the impact of local steroids on autograft-mediated spine fusion in large animals. Thank you.
This presentation is entitled Recent Complications in Spinal Surgery Performed by American Board of Orthopedic Surgery, Part 2 candidates over the last decade. My co-authors and I have no relevant disclosures pertinent to this presented work. So the background and methods of our project, basically the recent research has demonstrated the importance of surgical experience and clinical volume in minimizing complications after spine surgery. This is challenging for orthopedic spine surgeons who are just starting their practice. So we performed a retrospective review of surgical cases submitted to the ABOS by candidates taking the Part 2 oral examination between 2008 and 2017, who had a self-designated subspecialty of spine. We then performed multivariate Poisson regression analyses adjusting for confounders and used this to assess rates of complications and mortality over time. All analyses controlled for biologic sex, age, surgical diagnosis, and location. Our results, so we found that there were 37,539 patients who were analyzed in this time period. This averaged 3,754 cases per year and 49 cases performed per candidate per year. 760 candidates took the exam between 2009, 2008, sorry, that should be 2007, 2008, and 2017, which is an average of 76 per year. The average patient age was 54.7 years, and about half of them were male. Overall mortality rate was 0.5%, reoperation rate was 5.2%, and readmission rate was 5.7%. Overall medical complication rate was 8.5%, and overall surgical complication rate was 15.6%, and the overall complication rate was 24.7%. When we looked at incidence of surgical and overall complications, we noted that over this study period, the incidence of both of these increased significantly, with a 19.7% and a 20.2% higher incidence rate ratio, respectively, for surgical and overall complications between 2008 and 2017. By contrast, we noted that mortality decreased significantly, with a 52.2% lower incidence rate of ratio of mortality between 2008 and 2017. And what we noted is that there was a higher overall complication and surgical complication rate. And what's more is our overall complication rate that we found in ABOS candidates was higher than the literature reported rate of 16.4%. And we noted that while surgical and overall complication rates appeared to be increasing, we did find that mortality rates appeared to be decreasing. This may be multifactorial in the setting of potentially higher acuity patients, more frequent reporting or assessment of complications, or changes in training. And further studies may be helpful in elucidating the contribution of each of these factors. Encouragingly, however, we noted that mortality is decreasing, and this suggests that although complication rates appear to be increasing, with regard to patient safety, particularly with regard to life-threatening complications, these may actually be improving with time.
Good morning. Thank you guys for allowing us to present our work that we've done here at Walter Reed. Going to have a couple minutes on the effect of lumbar corticosteroid injections on postoperative infection and lumbar arthrodesis surgery. Currently injections are used quite frequently either in diagnostic or therapeutic pursuits in spine clinics, and the current literature is very mixed on if these can contribute to postoperative infection. You can see there's multiple studies that showed no difference between the injection group and control groups, and then others have shown a kind of a temporal association with infection rates after lumbar arthrodesis surgery with patients getting preoperative lumbar corticosteroid injection. So our purpose was to assess the overall rate of infections in the military health system, evaluate the relationship of preoperative steroid injections and infection rate, and determine the timing or the role of timing type and number of injections. And we thought that we wouldn't see any difference in infection rates in patients that were exposed to these injections. So we use it's a large retrospective review in our database. We looked through all of our patients that had lumbar arthrodesis between 2009 and 2014, excluding infection, revision, and malignancy, and we stratified by timing type. And what we found is patients, we had 3,400 patients who underwent lumbar arthrodesis, the majority of which of these are male, and the mean age is pretty low, 43. 612 of these patients had at least one steroid injection before their arthrodesis surgery, and you can see here it's broken down by epidural or facet. And about 2,700 didn't have any steroid injection before the arthrodesis surgery, and they're used as our control. So comparing our overall infection rates is 1.47%, which is on par to a lot of other previously published literature. And we didn't see any difference between our control and our injection groups here, no statistical difference. And breaking down by timing, we also try to establish any association with temporal association between injections and infection. And we can see here there's no increased risk or significant differences in the 0 to 90, 0 to 30, or any of our time differences compared to our control groups. Type of injections were also analyzed. Epidural injections and facet injections, there was no significant differences between the infection rates, and the number of injections did not have any bearing on the infection rates, with 39% of our patients receiving multiple preoperative injections. So discussion, we found that we had overall infection rate of 1.47% in the military health system. Preoperative injection and postoperative injection, or without preoperative injection or with, there was no significant difference between infection rates within the groups. So there's no differences based on time of injections, number of injections, or type of injection. And like I said, our overall infection rate was consistent with other literature. We had the same limitations that any large retrospective database review study does, and our results may not be exactly generalizable to everyone else's practice, seeing as that our young active duty population, with majority male, and like I said, our average age at 43. We also didn't go into significant detail trying to stratify by smoking, BMI, or diabetes. In conclusion, this is a large study in young, healthy population. We did not observe any exposure or dose-dependent relationships between lumbar steroid injections and infection. And further large prospective studies are needed to kind of better elucidate these relationships between injections and post-op infections. Thank you.
So my name is Ankur Ryan. I'm a second-year resident at UMass Memorial Medical Center and presenting my project entitled Clinical and Radiographic Outcomes of Surgical Management for Lumbar Degenerative Spondylolisthesis. So as we know, there are multiple surgical options for degenerative lumbar spondy, including decompression alone and decompression with fusion. The purpose of our study was to compare the clinical and radiographic outcomes of surgical management techniques for degenerative lumbar spondy. We used a retrospective review of a prospectively collected database of multiple surgeons at our institution of patients undergoing operative treatment for degenerative lumbar spondylolisthesis with at least 6 months of follow-up. And we collected multiple data points, including patient-reported outcomes and radiographic measurements. Our statistical analysis included paired t-tests and linear regression controlled for demographic variables. For our results, we compared 3 of the most prominent techniques within our database, including non-instrumented fusion, posterior instrumented fusion, and transfemoral lumbar interbody fusion. We found that all 3 procedures demonstrated improvements in patient rooms and ODI physical composites. Only minimal clinically important difference in ODI, which was a range of at least 24 pre-op post-op. In conclusion, all of our analyzed treatment options demonstrated improvement in patient-reported outcomes. However, only TLIF reached the threshold for a minimal clinically important difference in certain outcomes measures. This means that interbody fusion may provide greater clinical benefit, possibly due to improvements in disc height, neuroforaminal distraction, and sagittal alignment. However, further recruitment and longitudinal follow-up through our database is required to determine any long-term outcomes. Thank you.
Okay, so my name is Ariana Reyes, and I will be presenting risk factors for 30 and 90-day readmission after lumbar decompression surgery on behalf of the authors listed below at the Rothman Institute. And so just a quick background on our study. The purpose of the study was to determine patient risk factors for inpatient 30 and 90-day readmission after lumbar decompression surgery, given the changing reimbursement models and importance for preoperative planning and clinical decision-making. And so we included patients that underwent 1 to 4 level lumbar decompression surgery from 2017 to 2018. We then divided these patients into 3 groups: patients that did not have a readmission, those that did have a readmission, and patients that either had an ED, observation, unit visit, or urgent care visit. We then used univariate and multivariate analysis to compare the groups. And so after univariate analysis and comparing the 3 groups, we constructed a multivariable logistic regression. The results are seen in table 1. And so we found that age, current smoking, length of stay and history of renal failure were all significant predictors of 30 and 90-day readmission. We then looked at the reasons for readmission and found that around 48% were procedure related, and one of the most common reasons was site infection and dehiscence. And so overall, previously in the literature is reported that length of stay may not necessarily be a strong risk factor for readmission in contrast to the results of this study. However, other studies have also reported that a higher ASA score, more comorbidities were related with readmission, similar to the results of this study, in that we found that current smoking and history of renal failure were predictive of readmission. And then previously it was reported that around 12.18% of reasons were related to surgical site infection, similar to the percentage that we found in this study. Thank you.
Thank you, everyone. Today I'm going to be talking about the reherniation after decompression score and how it can be used to identify patients at low risk for reherniation after lumbar decompression surgery. So a bit of introduction and background. So lumbar decompression is a very effective therapy for herniated nucleus pulposus that's refractory to conservative management. Some studies have shown that patients experience a faster relief of pain symptoms and experience better outcomes with careful patient selection. Despite this, roughly 6% or even more may experience reherniation events somewhere in the future. To this end, we aim to develop a predictive scoring model to identify patients at risk for reherniation. But a method, so what we did was we designed a retrospective cohort study using our institution's patients from 2006 to 2018. All were treated with a lumbar microdecompression. Charts were reviewed for the following variables, and we aimed to build a lasso logistic regression model. From this, we identified a cutoff score and developed a RAD scoring tool to help identify patients at risk for reherniation. So as far as our sample goes, patients were around the age of 45. Most of them were male, BMI of 29, and an ASA score of 1.9. Most herniations were of the lateral recess variant, and 51 or 9.9% of the entire cohort experienced a reherniation event after decompression. When building the model, these were the variables that were identified as significant, and we found female sex, ASA score, number of operative levels, duration of symptoms, the type of herniated nucleus pulposus, in this case lateral recess, as well as a couple of radiographic parameters. When testing our model, these were our parameters, and we identified a sensitivity of 0.66, specificity of 0.83, decent AUC score, as well as pretty good accuracy. So for our low risk patients, only 3.4% experienced a reherniation event, whereas high risk patients, nearly 30% did. So to illustrate how this works, the point value column here shows the number or the value assigned to each variable. And using a hypothetical patient, in this case patient B, you can see exactly how many points someone would score. For a cutoff of 16, those above would be high risk and those below would be low risk. In this case, this patient would have a score of 17.02, and in this case would be high risk and can be counseled as such to be wary of future reherniation events. Thank you.
Okay, my name is Darren Section. I'm a former fellow at the University of Rochester. This is my presentation, Fusion and Decompression versus Decompression Only for Lumbar Facet Cysts. So these are disclosures for myself and for my co-authors. Lumbar synovial cysts, these are mucinous lesions that arise adjacent to degenerated facet joints and may contribute to stenosis. They were first described in literature in 1950. They may be associated with radiculopathy, back pain, and possibly facet joint instability, and management has remained controversial over the years. The objective of our study was to describe the complications, outcomes, and recurrence rates following surgical management of these lesions. This was a retrospective analysis in which we identified patients treated surgically between 2008 and 2018 so that we could have at least 2 years of follow-up data. We grouped them as either decompression only or decompression fusion patients. Total, we had 174 patients, 148 treated with decompression only, and 26 with decompression with fusion initially. The mean age was 63.4. There was a female preponderance, and the L4-5 level is the most common level affected, both of these last two findings being consistent with prior literature. In the decompression fusion group, there was a statistically significantly higher EBL, length of stay, and reoperation rate. The dural tear rate was not significantly different between the groups, and although there were more recurrences in the decompression-only group, this was not statistically significant. However, it did approach statistical significance, as you can see. In the decompression-only group, the reoperation indications included spondylolisthesis and cyst recurrence. Of the patients in this group that did have cyst recurrences, 4 were treated non-operatively, 3 were treated with refeed decompressions, and 5 with decompression fusion procedures secondarily. The decompression fusion group had reoperation indications including adjacent segment disease, pseudoarthrosis, and hardware complications. In conclusion, EBL, length of stay, and reoperations were significantly higher in the decompression fusion group. The durotomy rate was not significantly different between the groups, and although cyst recurrence was not significantly higher in the decompression-only group, it did approach statistical significance. With regard to future directions, we believe a prospective randomized trial may provide data of even greater significance on this subject. Thank you.
Hello, my name is Tony Makula. I'm a fourth-year neurosurgery resident at Mayo Clinic, and today I'm going to be talking about our study on the regional improvements in lumbosacral housing units following teriparatide treatment. Low bone mineral density is common in spine surgery patients and can lead to undesirable outcomes. DEXA is used to estimate bone mineral density but has limitations in the spine, whereas Hounsfield units represent an alternative way to estimate DEXA bone mineral density via a measure of X-ray attenuation on CT scan. Methods to improve low bone mineral density include anabolic osteoporosis medications, including teriparatide, which improves Hounsfield units in the vertebral bodies of the lumbar spine by 22%. But the effect on other anatomic structures in the spine is unknown. So the purpose of our study was to compare the regional Hounsfield units of the lumbosacral spine before and after teriparatide treatment, and second, to correlate regional Hounsfield unit changes with DEXA bone mineral density. We included patients who underwent a minimum of 6 months of teriparatide treatment and had pre- and post-treatment DEXA and lumbar CTs. We measured Hounsfield units in the vertebral bodies, in the pedicles and lamina, and also in the sacral body, the sacral ala, and the ilium at the S1 and 2 level, and also in the ilium above the sciatic notch. We included 40 patients in our study. The pre-treatment Hounsfield units were the lowest in the sacral ala and in the ilium above the sciatic notch, and we saw the greatest improvement in Hounsfield units in the lumbar vertebral body, the S1 ilium, the S1 vertebral body, and the ilium above the sciatic notch. DEXA also improved with teriparatide, with lumbar bone mineral density improving the most by 10%, and Hounsfield units correlated the best with total hip bone mineral density. So in conclusion, we found significant regional variation in lumbosacral Hounsfield units at baseline, with the lowest Hounsfield units in the sacral ala and ilium near the sciatic notch. We saw the largest percent improvement in the lumbar vertebral body, the S1 vertebral body, and the ilium above the sciatic notch. This study may provide information on how teriparatide can optimize lumbosacral fixation. Thank you.
Hi, everyone. My name is Gene Katzeben from West Virginia University, and I'll be talking about the use of liposomal bupivacaine in lumbar fusions. So liposomal bupivacaine, or LB, is FDA approved for administration into surgical sites for post-operative analgesia. The liposomal formulation allows for sustained effects for up to 3 days, making it appealing adjunct in multimodal analgesia, especially in spine surgery. The goals of this study were to describe the effects of LB in patients undergoing lumbar interbody fusion. Specifically, we wanted to address VAS pain scores, opioid consumption, and discharges and length of stay. This was a retrospective cohort study. Patients received LB versus those who didn't, and data points were collected at 12-hour intervals for 72 hours postoperatively. We had 97 patients in the LB group compared to 25 patients in the control group. Going into the results, the length of stay was significantly different between the two groups, about 2 days in the LB group compared to 3 days in the control group. Going into discharges, there were significantly more discharges at the 36 to 48 hour mark in the LB group compared to controls, a difference not seen at the other time points. Next, opioid consumption. There was no significant difference in total amount of opioids consumed or in how the opioid amount consumption changed over time. There were less IV opioids consumed at 48 to 60 hours in the LB cohort, but this was marginally significant and not seen at the other time points or with oral or total opioids. Lastly, with regards to VAS pain scores, there was no significant difference in overall pain scores or in how the scores changed over time. The mean VAS scores were higher in the LB cohort, but not significantly. The mean VAS scores were significantly higher in the LB cohort at 0 to 12 hours, a difference not seen at the later time points. So in conclusion, in patients undergoing PLIF or TLIF procedures, patients receiving LB had shorter length of stay, no significant difference in overall postoperative opioid use, and no significant difference in overall pain scores. Thank you.
Hi, my name is Kirk Thompson, and today I'd like to talk to you about my project, higher than expected rate of reoperation following limited decompression of lumbar facet cysts. I have no relevant disclosures for this talk. So some background, the treatment of lumbar facet cysts has been hotly debated over the last couple decades. Some authors advocate for pure decompression using microsurgical techniques, while as others advocate for decompression and fusion, concerned about reoperation rates. Those reoperation rates have varied from anywhere from 0% with decompression fusion all the way up to 15 to 20%. Our paper, we performed a retrospective review of patients treated at OrthoCarolina prior to January 2018 with limited decompression of lumbar facet cysts. They had minimum 2-year follow-up. Our primary outcome was revision. We also performed patient-reported outcomes, VR12 and ODI, and a radiographic analysis was performed to try to establish further causes of failure. We had 93 patients enrolled in the study with a mean follow-up of 3.8 years. 60% of the procedures were done at L4, L5, but they accounted for 74% of our failures. Overall, we had 19 revisions for a total of 20.4%. That included 5 patients with a second reoperation, as well as 1 patient who even had a third reoperation. Patient-reported outcomes, we found that 64% of patients at final follow-up reported minimal disability on ODI, but only 15.3% reported themselves to be much better. A radiographic analysis was done at the conclusion of the study, and specifically at the L4, L5 level, we found that sagittally oriented facets, first described by Bowden, as well as larger amounts of fluid on preoperative MRI at the L4, L5 level was associated with higher rates of failure. We also found that preoperative spondylolisthesis on upright imaging was not associated with primary failure. In conclusion, the reoperation rate for our study following limited primary decompression was 20.4%. We did find that facet orientation and large amounts of fluid in the facets at L4, L5 were associated with higher rates of failure. And in conclusion, we would say that the decision for decompression versus decompression fusion should certainly be tailored to the individual patient, keeping in mind the radiographic parameters that we've outlined prior. Thank you very much.
Hi, my name is Ali Pracha, and I'm a second-year medical student from Rush Medical University, and I will be presenting on how TLIF with cortical trajectory fixation, as opposed to traditional methods such as posterior lumbar fusion and traditional TLIF, has better early patient-reported outcomes. The purpose of our study was to look at this relatively new cortical bone trajectory technique by looking at radiographic outcomes as well as PROs and compare them to traditional TLIF and PLF. So we looked at all of the patients that received the cortical TLIF, PLF, or traditional PLF from 2017 to 2020, and then from a single surgeon, and then we excluded anyone with tumors, trauma, or infections. And then we had, in total, we ended up with 29 cortical TLIF, 103 TLIF, and 89 PLF patients. And for those patients, we collected radiographic parameters such as lumbar lordosis, pelvic incidence, and among others, as well as patient-reported outcomes such as VAS back, leg, ODI, and others. And then we did multivariate analysis to control for baseline characteristics to assess differences in clinical outcome with procedure type. We also looked at baseline characteristics and compared them using ANOVA and chi-squared. So what we found was that there was no difference in radiographic parameters in either of the groups, but when we looked at post-operative PROs, we noticed that cortical TLIF had better PROs compared to traditional TLIF, and all of these all of the groups, they all had about a mean follow-up for about a year. So for the conclusions that we made was that these short-term results, they suggest that cortical TLIF is an acceptable alternative for treating these various degenerative lumbar pathologies. And compared to traditional TLIF, patients who were receiving cortical TLIF, they actually had superior post-operative as well as final follow-up subjective outcomes. However, ensure to compare the longevity of these outcomes across these cohorts. Thank you.
Good afternoon. My name is Caroline Granger. I'm a fourth-year med student from the University of Miami, and I will be speaking about availability and variability of consumer prices for lumbar discectomy across U.S. hospitals in 2018. I'd first like to thank the Lumbar Spine Research Society for giving me the opportunity to give this talk. Given that pricing of surgery is not commonly discussed but is an extremely important factor for patients, we aim to examine whether there is available consumer pricing data for an elective lumbar discectomy, and if available, whether price varies based on hospital profit status and teaching status. Hospital representatives were contacted via telephone, hospital websites, and state transparency websites. A total of 153 hospitals were contacted via telephone calls under the guise of a patient requesting a self-pay price for elective lumbar discectomy. And then the same hospitals were researched for price comparison between those requested by phone and those listed on hospital websites. We ultimately grouped hospitals based on profit status and teaching status. This result highlights differences in available phone price when looking at hospitals stratified by profit status and teaching status, and the y-axis is showing frequency of price availability, while the x-axis denotes whether it was a partial or complete price. Here you see that complete prices were available at the highest frequency from non-profit hospitals in Figure 1A, and in Figure 1B, the teaching hospitals provide the most complete prices. This figure displays the frequency of price availability at hospitals stratified by profit status and teaching status based on what's available online. Few complete prices were available online for all hospital types. In summary, the mean complete price was $27,342, and private hospitals were shown to have lower prices than government and nonprofit hospitals. Ultimately, we found that there is much variability with regards to availability and comprehensiveness of pricing information for lumbar discectomy in the US. We believe measures to improve price transparency for this common elective procedure is warranted. Again, I'd like to thank the Lumbar Research Society for giving us the opportunity to talk. Thank you.
My name is Daniel, I'm a medical student, and today I'll be presenting on robot-assisted lumbar spinal fusion surgery. So I personally do not have any disclosures. Now, robot assistance has found its way into other surgical fields, particularly for lumbar spinal fusion. The evidence is mixed as to its usefulness. So in a meta-analysis, robot assistance versus fluoro CT navigation, there are fewer intraoperative screw repositions, but there are no differences in revisions. In an RCT of 60 patients, robot assistance led to actually lower % of good positioning compared to the free-handed technique. So that really motivated this study, which utilized a national database, specifically the Pearl Diaper Records database. And we matched in a 1-to-1 ratio robot-assisted LSF with a non-robot assisted LSF along key demographic variables. These are the outcome measures we looked at. So firstly, before matching, we noticed that there is an increased incidence in the use of robot-assisted LSF for the years of the study. And located down here are the comorbidities that we matched. So these are the two cohorts. So without further ado, onto the outcomes analysis. We found that there is actually a increased 2.4 odds ratio in comparing robot assistance to the conventional technique. And similarly, we're seeing increased rates of readmissions, 30-day complications, respiratory complications, surgical site infection, and implant-related complications with a robot-assisted LSF technique compared to the conventional. Furthermore, for opioid utilization, there's a prolonged opioid utilization at 6 months for the robotic LSF. So when we're breaking down the revisions, most of the revisions are due to infection. There's actually a 4.5-fold increase in the risk of revision due to infection with robotic surgery. There are limitations, of course, to this study, specifically being a database. We're not able to control for learning curve, and learning curve is a big thing to consider when adopting a new technology. And interestingly, in this preliminary analysis, across the years of the study, there's actually decreasing rates of complications, as you can see in the blue line, and the revisions in the orange line. So learning curve might be an important part of the equation we're missing. In conclusion, we're seeing that through this database study, robot assistance led to increased risk of revision, readmission, complications, and opioid use. Really, further researchers need to investigate this. Thank you.
Hi, this is Dr. Anton Jorgensen. Thanks for the opportunity. My co-authors are on this slide. I present a radiographic analysis of lumbar disc arthroplasty reoperations at a tertiary medical center. Disclosures are as attached, as shown here. I am a consultant, and the remainder of the authors have nothing to disclose. The purpose of this study is to define radiographic parameters associated with reoperation after a lumbar disc arthroplasty. A lumbar disc arthroplasty has been introduced as an alternative to fusion surgery to preserve motion. Lumbar disc arthroplasty in some studies has been shown to be associated with lesser rates of adjacent segment disease as compared to fusion. When compared to fusion, lumbar disc arthroplasty is equivalent or improved compared to fusion in regards to adjacent segment disease, patient satisfaction, return to work, and revision rates. 5-year survival of lumbar arthroplasty implants has been shown to be very high. However, the reasons for failure and reoperation have not been thoroughly investigated. This study is an 11-year retrospective review of arthroplasties performed at a tertiary center, a single institution. Patients with less than 2 years follow-up or insufficient x-rays were excluded. We identified 14 cases of reoperation after a lumbar disc arthroplasty, and we identified 44 control cases of no reoperation. Of the 14 reoperations that we identified, 9 were revised from an arthroplasty to a fusion. 4 were revised with a foraminotomy after the arthroplasty, and 1 patient underwent placement of a spinal cord stimulator. During our radiographic analysis, we measured parameters such as lordosis of the disc space, disc height, and the position of the implant. Demographic data, average age of our patients was about 37 or 38 years old, and the cases were all operations at L4, L5, and L5S1 level. With respect to our results, what we found was that overstuffing of the disc space, in other words, excessive implant disc height after placement of the implant, was associated with reoperation. The biggest factor associated with odds of reoperation were containment of the implant within the disc space. An implant that is not fully contained within the disc space had 5 times higher odds of requiring a revision surgery as compared to implants that were fully contained within the disc space. So we define an implant that's fully contained within the disc space as an implant that on the lateral view is within 2 millimeters of the posterior disc space or within 2 millimeters of the anterior aspect of the disc space. So an implant that's fully contained within the disc space had a very low odds of revision surgery. So our conclusions, we found that factors associated with an increased risk of lumbar arthroplasty revision surgery are overstuffing of the disc space and implants that are not fully contained within the disc space. An implant that is sticking out the anterior aspect of the disc space or sticking a few millimeters into the spinal canal is associated with revision surgery. I do thank you for your time.
The study being presented is entitled Primary versus Revision, a comparison of outcomes following minimally invasive lumbar decompression. The aim of this study is to investigate differences in the postoperative patient-reported outcomes following minimally invasive lumbar decompression between primary and revision procedures. This was a retrospective review of a prospectively maintained surgical database for primary or revision, single or multi-level minimally invasive lumbar decompression procedures from December 2013 to July 2019. The primary outcomes of interest were patient-reported pain, disability, and physical function. Between group comparisons of patient demographic and perioperative characteristics were conducted using chi-square or t-tests. Paired t-tests were used to assess improvement in patient-reported outcomes, and a linear regression was used to determine differences in outcome scores between the primary and revision groups. Total of 517 lumbar decompression patients were included. The cohort's mean age was 47 years, 31% were female, 42% were obese. 451 patients underwent primary procedures and 66 underwent revisions. Primary and revision groups differed in prevalence of AIDS and peripheral vascular disease, and operative duration was significantly longer for the revision group. Both groups demonstrated significant improvements in all outcome measures at all time points. Revision patients reported poorer preoperative physical function and worse pain and disability at 12 weeks and 6 months postoperatively. However, by 1 year, no differences were observed in any of the primary outcome measures. In conclusion, although significant differences were demonstrated at preoperative and several intermediate time points, patients may experience similar long-term benefits in terms of pain, disability, and physical function following both primary and revision minimally invasive lumbar decompression procedures.
Hi, my name is Dr. James Stockman. I'll be talking about high revision rate after microdiscectomy for far lateral disc herniations at 2-year follow-up. I have no disclosures. For background, we all know that far lateral disc herniations have a poorer and more variable outcome as compared to paramedian disc herniations. There is, however, a paucity of literature regarding the surgical outcomes for far lateral disc herniations and the incidence of revision surgery. For our study, we did a retrospective review of patients at OrthoCarolina treated prior to September of 2017 who underwent a microdiscectomy for far lateral disc herniation. We had a minimum 2-year follow-up, and our primary outcome was revision surgery. Secondary outcomes were preoperative versus postoperative leg pain, back pain, and motor weakness. For results, we had 149 patients who met inclusion criteria, with 115 having 2-year follow-up. We found a 30% revision rate among these patients, with a median time from index surgery to revision of 20.9 months. Of revisions, 20 were fusions, 11 were decompressions, and 3 incision and debridements. 4 patients ultimately underwent a second revision surgery. In conclusion, in patients with 2-year follow-up of microdiscectomy for far lateral disc herniation, 30% of patients required revision surgery. I'd like to note that even if none of the patients lost follow-up required revision surgery, there is still at least a 23% incidence of revision surgery. This information may prove useful for patient counseling and surgical decision-making for treatment of far lateral disc herniations. Thank you.